So today we're going to talk about the approach to dogs with chronic head or cervicogenic pain, that is pain in the upper neck. And I'm going to tell it from the perspective of one of my favourite patients, Deazel. This is his story. So when I first met Deazel, he already had a 3-year history of pain, which had been localised to the region of the right head, ear and neck. He's an older boy, and so he had a few other issues going on that included a polyneuropathy, which also included a laryngeal paralysis and a hypothyroidism for which he was medicated for. The polyneuropathy had been diagnosed by electrophysiology and a muscle biopsy. But this was a new and different problem unrelated to that. And the signs reported were poor exercise tolerance associated with panting that was not related to the laryngeal paralysis, facial grimacing, especially on the right side, which his caregiver referred to as a pain face, vocalization when he was rolling on his back, unwillingness to turn to the right, behavioural changes such as he no longer would carry toys in his mouth, and he sometimes spent a lot of time at the water bowl drinking, but not without any difficulty drinking, just taking a long time to drink. His sleeping was impacted in that he was noted to often have a very uncomfortable looking position lying on his left side, and he would no longer roll on his back. And he was under the care of pain clinician Liz Curtis, who made a lot of very astute observations of him, including that intermittently he would have his tongue deviated to the left and that he was consistently painful. She always got a pain reaction when she pressed in the region of the C1 nerve root as it came out the rostral edge of the atlas. However, all of these clinical signs had a lot of variability. They tended to wax and wane, and consequently it was very difficult to correlate what could trigger them, or whether a drug actually made it better or it just happened to get better by itself. So we're going to discuss the differential diagnosis of head and upper neck pain with an emphasis on neuropathic pain. So we can divide the causes of pain into nociceptive, nociplastic, and neuropathic. So nociceptive pain is pain due to damage to non-neural tissue, for example, musculoskeletal or visceral tissue. And I would include acute disc extrusion in that, because if you were to remove and deal with the acute disc extrusion, then the animal will not be left with a persistent pain state because there hasn't been permanent damage to that nociceptive pathways. Nociplastic pain is when you have pain from altered nociception without actually any clear evidence of damage that is causing the activation of those peripheral nociceptors, or no evidence of a lesion of the somatosensory system causing the pain. Now, what's included into this classification does appear to vary. Easier ones are human conditions like fibromyalgia and pain associated with some abdominal conditions like IBS, cystitis and pancreatitis. However, many people also include osteoarthritis in that classification, because although you have that ongoing inflammation, there is a process which perpetuates that pain beyond what that inflammation would be expected to do. And then we have neuropathic pain, where we actually have pain due to damage to the nervous system itself, either the central or peripheral nervous system. So another example of nociceptive pain would be tonsillar carcinoma, which, as many of you know, is an extremely painful tumour. We can just see one popping out a tonsil here, and here it is on MRI scan. And this dog was presented to me with a possible neurological cause of his pain because he had a very sudden onset change in behaviour, including uncharacteristic aggression to his caregivers and other dogs. And this is what we found. Differential diagnosis of chronic pain, I like to kind of divide it into these 6 categories. And we're really going to consider here the chronic causes of head and upper neck pain. So I'm not including acute disc disease or steroid-responsive meningitis or meningoencephalomyelitis, which are, of course, are very important causes of acute neck pain. So chronic musculoskeletal pain, things like temporomandibular joint pain, atlantoaxial and atlanto-occipital, and disease of those complex joints in the cranial neck. Chronic visceral pain, actually difficult to find some that, since there aren't viscera in the head. However, there is an increasing role being suggested of the gut-brain axis and dysbiosis in migraine in humans. And we have had a couple of cases reported of migraine in dogs. So I'm including that for that reason. Then we have chronic peripheral neuropathic pain. So the classic examples of that would be trigeminal pain, such as a nerve root tumour, feline orofacial pain syndrome if we were considering cats, and radiculopathy is nerve root disease of the C1 to C3 nerve roots. Then we have chronic central neuropathic pain. So the classic ones for that are Canine Chiari pain and Syringomyelia. Chronic cancer-related pain, so there's many examples of that. Many of these in the dog, however, aren't chronic. But we also have to consider pain because of the treatment. And I've seen a number of dogs that have had radiotherapy due to brain tumours that have presented with ongoing headaches. And then we have quite an unfortunately common category of chronic post-surgical or post-traumatic pain. The classic one with that is pain mediated through the trigeminal nerve due to dental disease or damage. So dental procedures themselves where being over enthusiastic with drills, damaging the trigeminal nerve, or with tooth root fractures, setting up a chronic trigeminal nerve damage and neuropathic pain. And then chronic post-operative pain following ear surgery or potentially cropping. And post-surgical pain I've certainly seen following atlantoaxial surgery. So to understand what causes pain in the head and upper neck, we do need to understand a little bit of anatomy. So the most important nerve is the trigeminal nerve, which has all sensory information coming from the face, the mouth, and the rostral 2/3 of the tongue, and also the meninges. The facial nerve, many people think it has a big sensory component, but they're confused by that, and actually it only does a very small part of the face. It's mostly motor, and that bit of the face that it does is the inner surface of the ear, so the concave surface of the inner ear, and the external auditory meatus, so the external lateral ear canal. Of course, it does have sensory with regard to taste, but that is not what we're considering here. We're considering nociceptive information. Then we have the C1 nerve root. That I'm considering here most importantly because this is where pain specialists have found pain in Deazel. That does have information coming from the meninges and also has some proprioceptive information coming from the tongue via the hypoglossal nerve, which is the hypoglossal loop. And that is going in through there and also in through the C2 nerve root. The C2 nerve root is incredibly important, giving sensory information to the back of the head and the ears and also the meninges. And the C3 nerve root is doing the cranial neck. Now, I'm a very visual person. I don't like reading anatomy, I like to see anatomy. So here's some pictures. So the cutaneous areas of the C2 nerve root, 3 branches to that nerve: the greater occipital nerve, the greater auricular nerve with the pale green area is doing the crossover there. And then we have the transverse cervical nerve. So really the sort of back of the ears, back of the head, upper neck. Then we C2 nerve roots now represented in yellow. Then we have the trigeminal nerve, which is the majority of the head, and then the facial nerve, which is the inner part of the ear, and then the C3 nerve root, which is the upper part of the neck, including the very back of the neck. So when we were considering pain in this distribution, this back of the head distribution, there are 2 main differentials with regards to neuropathic pain, and whether you consider one more than the other really comes down to signalment. So if it's a toy brachycephalic breed, then you're going to consider Canine Chiari pain and Syringomyelia. And if it is a larger breed, then you're going to consider first C1 or C2 nerve root disease. So in canine Chiari malformation, obviously there are many other videos of this on my YouTube channel, and I would refer you to that. But briefly, this condition is characterized by selection for brachycephalic features and a well-defined stop. So the normal cavalier has a larger head and has some frontal sinuses and a stop that has a more gentle slope. This is all reduced in this more severely affected baby-faced cavalier, and the reduction in this part of the brain pushes the brain back, less space, overcrowding of the CSF channels and reducing the compliance of the brain, which is thought to be an important part in the pathogenesis of the pain syndrome. These are representing MRIs that are going between the spectrum of changes that you see in Chiari malformation and Syringomyelia. And this really is because all cavaliers have a degree of Chiari malformation. And so we have to recognize that not all of them have clinical signs of disease. And that goes for the other commonly affected breeds like the Poms, the Chihuahuas, and Griffon Bruxellois and Yorkshire Terriers. So the normal dog has a rugby ball or American football shaped brain and an angled stop, which is more of an obtuse angle, that junction between the frontal bone and the nasal bone. And if you were to draw a line between the occipital crest and the episthelon of the foramen magnum, to the bottom of the supraoccipital bone, then it shouldn't bisect the cerebellum like it is here. And there is a low angle, a large angle between the craniocervical junction, so almost going into a flat line here. As you get more severe disease, first of all, this is not entirely representative because this is a much, much smaller skull. I've just scaled it up here. The brain becomes more like a football. You get this acute angle at the stop, which I've given it some leeway here, this right angle going in here, because obviously this dog is really an indented stop. We have this line bisecting the cerebellum. We do have some cerebellar herniation, but I'd like you to not focus on that too much because it really depends on whether or not this foramen magnum is big enough for the cerebellum to come out. And in this instance, it really isn't. Although the supraoccipital bone ends here, this is the membrane between the occipital bone and the atlas, and the cerebellum can't flop out, and it would be a mistake to interpret this as not having as severe Chiari malformation as this dog. You also get this flattening of the frontal areas and ventral deviation and reduction in the olfactory bulbs. As you get towards the Syringomyelia phenotypes, then you get increasing overcrowding in the craniocervical junction, so this angulation between the basi-occipital and C2 becomes more and more acute, and there is more overcrowding in this area, and you can see mild Syringomyelia here and a much wider syrinx here. You also get variable ventricular dilatation, which is represented by the blue spots, but the most consistent dilatation is in the fourth ventricle because of obstruction through the lateral apertures. So canine Chiari malformation and Syringomyelia, as I said before, is a spectrum. So CMN is clinically normal dogs, but on MRI they may show a Chiari malformation. Chiari malformation pain, or CMP, signs of pain reported by the caregiver, or behavioural signs, or you found clinical signs, and they have that MRI appearance of CMs. SM may or may not be present. Mild Syringomyelia, so mild Syringomyelia has been detected on MRI, but they have no specific signs related to the Syringomyelia. They may have Chiari pain. It's typically a small symmetrical syrinx with a maximum transverse diameter of less than 4. And then we have severe Syringomyelia, so they have specific clinical signs of Syringomyelia, and that relates to the spinal cord damage. They may have spinal phantom scratching, scoliosis, weakness, or ataxia. And the localization of the syrinx corresponds to the neurological signs. It's typically a large syrinx, and they typically also have Chiari pain, which might be very, very severe. So what are the clinical signs of Chiari pain? Well, classically, they will have pain related to rapid postural change, things that would mimic the Valsalva maneuver. So the Valsalva maneuver is forced expiration and raised intrathoracic pressure against a closed glottis, but there are many things that can mimic that, such as coughing and sneezing, and in the dogs, lifting them up, especially if you lift them under the shoulders and rapidly lift them towards, say, a consulting room table, jumping or rising. So the dogs may vocalize or may avoid that. Head pain, so like this dog here, facial grimacing, rubbing the face, scratching the face. They may have spinal pain. This is usually pretty localized, unlike disc disease, more common in the cervical area, over the thoracolumbar, over the lumbosacral, but it could be in all of those places. Hypersensitivity to touch. You can see this dog here is rather anxious about having her head touched. An activity change. So this little girl here much prefers at this point in time to be traveling in that buggy. Sleep disruption, so either a disturbed sleep or sleeping with an elevated head or other unusual posture. A change in behavior to other pets or people. So this little guy here is showing some aggression, repulsive behavior towards his owner, who's trying to move him away from the area with a pillow, not touching the dog, just using that to protect his feet. And then forelimb hypermetria. So usually this is quite subtle. I apologize for the pixelation of the photo, but it's quite difficult to catch this in a photo. And this dog had a more obvious hypermetria. And here's another example of pain face. So all of these signs, you could argue, are relatively non-specific, and so I would compel you to use something like Chiari check, which gives you a Chiari score and also a Syringomyelia score. Syringomyelia is a central spinal cord problem, so fluid cavities develop inside the spinal cord, and they usually also have central neuropathic pain, so they usually all have signs of Chiari malformation pain, and they may have phantom scratching, and this specifically relates to damage by the syrinx to the superficial dorsal horn nerve root entry zone. And so you see this asymmetrical syrinx, which is like a slash going through the spinal cord. They may have allodynia, so increased sensitivity to touch, or you may be suspicious of paresthesia, like in this dog, where she is constantly licking her forepaw here. And in this guy as well, you can see the lick staining around his toes and up the antibranchium. This guy is also quite weak. We can see his palmagrade stance. You may also see cervical torticollis, also associated with superficial dorsal horn and grey column damage. Weakness that is predominantly of the thoracic limbs or the thoracic spine. And very much more uncommonly proprioceptive deficits, but this is again typically of the thoracic limbs. So there are two types of scratching with canine Chiari malformation and syringomyelia. The first is associated with head pain, we think, and seen in Chiari pain when the dog is rubbing and scratching at their head and possibly the upper neck. And the second is phantom scratching, which is associated with damage to the specific segments of the spinal cord associated with the scratch reflex. It's a maladaptive scratch reflex that can be elicited by rubbing the affected dermatome. Classically, the dogs don't make skin contact, and you often see it when they're walking on a collar like this. So that is brachycephalic toy dogs, but what about Deazel? His signs suggested that he had pain in the area of the C1 nerve root, but since that has less sensory, we also considered the C2 nerve root. He had restricted turning to the right. He avoided laying on the right. He had this grimacing expression. And as I said before, we had the suspicion that he had tongue dysesthesia because his tongue tended to be deviated to the left, and he would often have a grimacing expression. He spent a long time drinking, and he was no longer picking up his toys. As you can see, he seems to be consistently sort of pulled to the left side, with perhaps the right side, which is meant to be the abnormal side from a pain perspective for him, perhaps having less tone. Another shot here. And once the caregiver it had been pointed out, it was something that you couldn't not see. And again, he looks very distressed. So I wondered if Deazel had neck-tongue syndrome. Now, this is a very rare condition, even in humans. And it is described as a rare headache disorder that's provoked by sudden rotation of the neck. There are various different causes. The most common is compression of the C2 nerve root. It's also described with Chiari malformation, with whiplash injuries, idiopathic and familial forms occur. And what is unusual about this condition is that they also have tongue dysesthesia, and this is because of phenotypic change to the proprioceptive fibers from the tongue that are entering through the C2 and presumably also C1 dorsal nerve root. And when you get a central sensitization, you can get nerve fibers that had one job, for example, touch, taking on a different job, pain. And that's essentially what happens with allodynia, that touch actually is interpreted as painful. But it can also happen with damage to proprioceptive fibers. So position can also become painful. And so people with this condition describe tongue sensory disturbances such as numbness, burning, and paresthesia, that should say. And with Deazel's collection of signs, you did wonder that. And I've just put this anatomy picture here from Miller's Anatomy of the Dog, just really to show that C2 nerve root and how it comes out and goes up to the back of the head here. And this is the C1 nerve root, and this is where you pressed on here, where Deazel reacted. And so Deazel had a lot of investigation, and I wasn't the only person to investigate him, but we did CT because of the possible neck-tongue syndrome. We tried to do a dynamic CT, although that's quite difficult to achieve rotationally. And we did MRI, and really, apart from some very equivocal changes of possible contrast enhancement in the C1 nerve, there wasn't really anything to find apart from normal anatomy. CSF analysis had previously been unremarkable. So, how do you make a diagnosis of neuropathic pain? Well, I like to think of it as trying to fulfill 4 categories. There may be, for example, a known lesion, a damage to the nervous system, for example, the Chiari malformation or Syringomyelia, or perhaps there's a history of trauma to that region or surgery to that region, for example, the atlantoaxial subluxation surgery, and perhaps fixation so as to pinch on those nerves. We should find evidence of abnormal sensation, so decreased or increased sensitivity to touch, and hopefully we'd have diagnostic tests to support that, MRI or electrophysiology. But as in the cases of Deazel, you may not always get that. And you have to bear in mind that neuropathic pain, actually, although I've put it down here as a diagnosis, is actually more of a description. It's a bit like saying an animal is anemic without describing why they are anemic. So you have to find out why. So in some instances, you may have to resort to a treatment trial of drugs that are effective for neuropathic pain. So what sort of drugs are we talking about? And this is my treatment algorithm for neuropathic pain. I have a separate one for Chiari malformation, but it's really very similar to this one. So we can divide our diagnosis or suspected diagnosis into peripheral or central. If it is peripheral, then there may be an option to use anti-nerve growth factor monoclonal antibodies. This is licensed for osteoarthritis. I will use it off-license for peripheral neuropathic pain syndromes, often with good effect. For example, it seems to be quite effective for feline orofacial pain syndrome, as we were talking about dogs here. You can use long-acting glucocorticoids. Most common reason for this would be lumbosacral disc disease using epidural methylprednisolone. Otherwise, we resort to the gabapentinoids, and I tend to start with gabapentin and then switch to pregabalin. And I'll give all my first-line therapies at least a 4-week trial. If that's not effective, then I'll start combining things. And this is our second-line therapy, so a combination of the first line, adding gabapentin, for example, if you've already started with that, and possibly considering ketamine subcutaneously, or a combination of topiramate and gabapentinoid. Now, topiramate's an interesting drug. I have a YouTube video on it. It's licensed for migraine in humans. Since the mechanism of headache is not well defined in many of these cervicogenic headache disorders, topiramate can actually sometimes be quite effective. And then in rare cases, I'll switch to phenobarbital in feline orofacial pain syndrome, because that sometimes can be an easier drug, especially as we can give it once daily. Third line treatment, and so again, will be after a 4 to 8 week trial, or at least. Then we start adding other things. So this is when we might add mantidine or memantidine. I rarely, if ever, use tramadol, but if that's something that is in your pharmacy that you have had success from, then perhaps you would like to try it. I find it very ineffective for dogs. Amitriptyline, I rarely, if ever, use. And again, if you want to use CBD oil, I guess this is the point to add it. But remember that you need to use a very high dose and therefore monitor liver enzymes. And in extremely rare cases, I might switch to carbazomepine in feline orofacial pain syndrome, but I've only ever had to do that in one case, and that's in over 30 years. So just some brief explanation of some of those drugs. So the monoclonal antibody, so these are things like Silencia and Librela. The nerve growth factor is bound to tyrosine kinase on the nociceptor and goes up to the dorsal nerve root ganglion to induce some gene transcription, and that will result in overexpression of many compounds, including the substance P and calcitonin related peptide, and lead to this whole central peripheral sensitization. So if we could stop that happening, that would be a good thing. And so that's what the monoclonal antibody do. They target that nerve growth factor, leading to a reduction in that. So it's only indicated for peripheral neuropathic pain. For central neuropathic pain and peripheral, we have the phenomenon of wind-up. So what happens is normally you have a glutamate that's coming out of the C fibers, and also substance P, which binds the neurotachykinin receptor. This will result in an action potential. And if there's enough of that, the magnesium block will remove itself from the NMDA receptor, and that will result in quite a few changes, including increased receptors on the postsynaptic terminal, nitrous oxide release into the presynaptic terminal, and encourages more neurotransmitter release, so-called synaptic hyperexcitability. And when this occurs in the dorsal horn, we call it wind-up, and that can lead to other changes in the spinal cord called central sensitization. So our first line of action is our gabapentinoids, and they prevent that glutamate release. So it reduces that wind-up and therefore that central sensitization. And then we have the possibility of using ketamine. And what ketamine does is it blocks that NMDA receptor site so that that glutamate cannot bind. And it also has many other actions. It's anti-inflammatory, increases dopamine, blocks serotonin receptors, and can help restore spinal cord inhibition. And so we will often use ketamine intermittently to reduce the wind-up in some central neuropathic pain conditions. And then finally, we have the NMDA receptor antagonists, such as amantadine and memantine, and they actually have that interesting 3-ring structure which binds to that magnesium site. So how does Deazel fit into that treatment plan? Well, when I saw him, he was receiving meloxicam for his body weight, memantidine every 12 hours, paracetamol, his thyroid supplementation. He was having regular sessions with his pain specialist, including acupuncture, electroacupuncture, massage, and fascial release. Management that they had tried and failed was diazepam, oral corticosteroids, and gabapentin. And so we made an assessment that, based on the history and ruling out everything else, that there was signs that could be consistent with right C1 and C2 dorsal nerve root damage. So we decided to try a nerve block in this area that was both therapeutic and diagnostic, because obviously a response to that would help confirm that this was the localization for his pain. And so he had some local anesthetic and long-acting prednisolone instilled over both nerve roots. They were performed with a nerve stimulator needle so the pressure could be monitored and kept low. He also had a ketamine infusion. The longer that you can infuse ketamine, the more chance you have of wind-up being reduced. And this was started 2 hours before the procedure and continued overnight for 21 hours. So here we can see the injection using ultrasound guidance, placing the needle in here. After localizing the area, we can see the needle going through, and this was the injection for the C2 nerve root. See the needle going through, identification of the nerve, and then making the injection. You can just see the fluid filling in the bottom part of the video. Assistant there making sure it's not under too much pressure. So how did he do? Well, I'm going to let the owner tell you in her own words by showing you the video that she created that starts from the day before injection to a few days after injection, and then 4 months after injection. And just for a note of clarification, when she mentions the High Force walk, High Force is a beautiful waterfall that is very close to where I work at Wear Referrals. I strongly recommend you visit this very beautiful part of the UK.
So this is the walk up at High Force. No major incidents, but he wasn't brilliant. He was very quiet, lackluster, not really engaging. His tail very down, normally a lot more upright than that. But the big standout for me was the photographs I took. Even when he wasn't pulling a pain face or grimacing at me, he just wouldn't turn his head and look at me. He was sat going through the motions, doing as he was told, but not sort of actively engaging or bright-eyed, just very lackluster. Gordon was on the way over to see Liz for pain clinic on the Saturday after he got back. You can see the difference in his tail here compared to that first video. This is what his tail is normally like when he's feeling good. Days after he got back, and here he is running downhill. Definitely more active than the High Force walk.
So Deazel made an excellent response to the blocking of the right C1 and C2 nerve root, which really supported a diagnosis of disease in that area, especially as no therapy had made so much difference in the past 3 years. He was started a couple of months later on monthly monoclonal antibody therapy. His meloxicam was decreased from daily to as per needed. He continued the paracetamol with an increase in dose if necessary. He does occasionally suffer from orthopedic disease. And his memantidine was withdrawn. He continued attending the pain clinic, and he was tried on grapetant and pregabalin, but that did not suit him. And so, on the whole, a very good outcome. He remained completely clear of clinical signs for 6 months after the injection, and then had a recurrence following an ear clean, which is interesting. Not for Deazel or his caregiver, it wasn't interesting at all, but from a pain perspective point of view, because obviously in the distribution of those nerves, I think he's hypersensitive to having any kind of trauma to his ears. But that was also managed with more aggressive pain relief at the time, including ketamine and antibiotics for the ear disease. And at the current time, we're planning on repeating the injection as and when he needs it. So, what conclusions can we make about working up neuropathic pain conditions in the dog? Well, it's important to precisely document the pain, and I ask the right questions to the caregiver. I think that my ability to think of the rare syndrome, neck and tongue syndrome, was entirely down to the excellent notes made by his pain specialist and Deazel's caregiver, really sort of accurately documenting all of the signs that they saw. Neuropathic pain affects dogs' movement, it affects their sleep, it affects their behavior and their emotional state. It may cause vocalization, and you also need to ask questions about history of injury. Where is the distribution of that pain? And what is the neuroanatomy that goes along with that distribution? This is when you get out your anatomy books to see if you can make sense of it all. Is there altered perception? This is a very key part of neuropathic pain, that there may be allodynia, so increased sensitivity to stimuli that shouldn't be painful, like touch or movement of the tongue in this case. Or there may even be numbness that you'll be able to demonstrate. So, which is quite an irony that the animal doesn't feel touch but has increased sensitivity. Then we have our diagnostic workup, not available to all, and in some instances might not be that revealing, but in the case of Chiari malformation and Syringomyelia, that's really quite a key part. And then finally, we have response to therapy, for which I would recommend using their treatment algorithm. So at this point, I'd like to thank Deazel and his caregiver for allowing him to teach us about neuropathic pain and its management. And thank you also for listening. Goodbye.